Okay, everybody, how we doing? I am giving this one final shot to get this upper airway lecture out. I think that we have connection and we should have audio. So here we go. We're going to talk about upper airways. This is chapter 31. I want to give you a quick overview because we didn't discuss this in detail in class, and so I feel like this could be helpful. Anyway, upper airways, one of the most common illnesses are URIs, upper airway illness, that people seek care for. These illnesses can be acute or chronic and account for nearly 20 million absences from work per year. As far as a nursing standpoint is concerned, we need to recognize signs and symptoms of URIs and educate the general public and be able to manage our patients safely and effectively. Rhinitis is a group of disorders characterized by inflammation and irritation of the nasal mucosa. And if you look on page 823 in your textbook, table 31-1 talks about the different types of rhinitis. And so when we talk about those, we talk about both infectious and non-infectious, or the two different types. When we're talking infectious, we're talking about the common cold. We are talking about a virus. Um, when we talk non-infection, we are referring to an allergic reaction, maybe a perennial reaction or an occupational exposure type reaction. The difference between allergic and non-allergic is that IgE-mediated response. And we talked about this in class, that sometimes if you want to try to differentiate between an allergic reaction and a common cold, you can do a CBC on a patient and see if their eosinophil count is elevated. So that's the difference. That's the IgE-mediated inflammatory response. Non-allergic obviously has not that response by IgE. Some of those factors that can cause rhinitis that are non-allergic in nature are change in humidity, cocaine use, pregnancy, or maybe just women on their menstrual cycles. Some components that, well, the most common factors that trigger allergic rhinitis are food, pollens, and animal dander. That way, if you want to have people over, say you have a cat and you have people that are allergic to cats, one of the ways that you can help their visit to be more comfortable is to actually bathe that animal besides just vacuuming and cleaning your house well before. If they go down the road of anaphylaxis, then certainly they should not even be in your home if they know that trigger to their rhinitis. This tends to be a familial problem. Signs and symptoms that you'll see in patients with an allergic or a non-allergic are pretty similar. There's swelling and congestion of the nasal mucosa. Mucus production goes up. Rhinorrhea, which is runny nose, nasal congestion, itchy, sneezy, cough. You see those people on TV in those commercials. I think especially interesting here is the pediatric population and how they present. They will produce a triad of signs and symptoms, and that triad is an allergic shiner, an allergic crease, an allergic salute. When we talk about that allergic salute in kids, it's how they will frequently wipe their nose with the palm of their hand, and that's what they talk about with the allergic salute. And that's one physical assessment indicator or inspection type thing that you will recognize that children do with this disorder. They have constant nasal dripping, dry mouth, chapped lips, and we already talked about how adults present. The pharmacological treatment for URIs, actually antihistamines are kind of the mainstay. We want to block that IgE-mediated response, thereby reducing inflammation and the symptoms that the patient experiences. The only problem with the antihistamines, and the one you're almost most familiar with, is Benadryl, is the side effects. So it's sedative and has cholinergic effects. Um, a nicer drug with less side effects would be a second generation antihistamine. So Allegra is a good example of one of those. But of course, that takes a prescription, but Allegra has less side effects than Benadryl. Some other drugs that are on the table here: intranasal corticosteroids, decongestants, and ophthalmic agents. Nasal sprays should come along with patient education so that the patient can administer those um, effectively. So your patient playbook feature on page 827 helps you or describes the patient education that goes along with administering a nasal spray. So for nursing standpoint, with medications, so the proper dose, the time, and the side effects, we want to teach our patients to avoid the triggers, to control their environment, and then we already discussed the medication administration. So our treatment goals here are to optimize the signs and symptoms control or the symptomatic control and prevent secondary bacterial infections. These are viral in nature, so there's no cure, and typically no antibiotics are indicated in these illnesses. Now, let's not forget the usual things. We want to increase their fluid intake so that we can thin their secretions. We want them to rest, nasal decongestants, antihistamines. For sore throat, patients can take warm saline gargles or suck on some throat lozenges. The biggest complications you'll see with these URIs are otitis media, sinusitis, epistaxis, which is a nosebleed, and laryngeal edema. The laryngeal edema comes with a patient that's having an allergic form of the rhinitis, and we always worry about angioedema in those patients, so we want to think ABCs for those patients. And a good way to ascertain whether or not the patient is developing airway or problems or is potentially going down that bad road is have them stick out their tongue. If their tongue's starting to swell, then you know that you probably need to act sooner than later. Quickly, they become your priority of care. And then kids, their eustachian tubes are very small, so when they get an upper respiratory infection and they get congested, those tubes do not drain well, and then they frequently develop those secondary bacterial infections. Sinusitis, let's talk about that. Most of these are viral, even though it seems that everybody that gets sinusitis takes antibiotics. Studies have proven, evidence-based research, that they're viral. They could be either acute or chronic. Chronic is defined as lasting 6 or 8 weeks. Some predisposing factors developing sinusitis are allergic rhinitis, which we've been talking about, upper respiratory infections, which that's a subtype of, is the most common precipitator. Nasal polyps, immunodeficiency factors, environmental issues, smoking, and secondhand smoke are all potential causes of sinusitis. Table 31-4 on page 828 talks about the symptoms of sinusitis. But what is important for nursing is that we do a very thorough head and neck examination. The goal of treatment should be prevention, but if it should occur, we want to eradicate that infection and shrink that nasal mucosa. So prevention and treatment, educating the patients on self-care, taking all their antibiotics if they're indicated, warm compresses may be indicated, humidifiers, vaporizers, adequate hydration, smoking cessation. One note that if you're utilizing a humidified air or vaporizer, then those should be cleaned daily and they should have a filter in place. Pharmacologically, for sinusitis, antibiotics, if indicated, are a 14-day course, so always we want to encourage our patients to take the complete course. Won't want to build resistance. Decongestants, topical steroids, Tylenol and Motrin for the pain and the discomfort and the inflammatory response. Certainly, antihistamines really are not indicated in sinusitis because they dry secretions. and so therefore we try to stay away from those medications. If both antibiotics and conservative treatment fails, then we will can resort to some surgical repair in special cases. So that's sinusitis. Just one note, when you're teaching your patients about Tylenol and Motrin dosing, it's especially important in the pediatric population that you educate your parents appropriately. On those bottles, that they give you a ballpark of medication based on weight. So Tylenol and Motrin have very specific designations for dosing. So Motrin, or ibuprofen, is 10 milligrams per kilogram. Tylenol has both a regular and extra strength option. So in Tylenol, it's 10 to 15 milligrams per kilogram. So you have to take that child's weight, you have to convert it to kilograms, and then you have to multiply it by the 10 or the 15, whichever is indicated. And can we give both of those together? Why, yes, we can. They do not interact. Those are two different drugs. And we will, in the emergency department, when patients come in, if they have very high fevers, we might hit them with both of those medications to quickly bring down their fevers. But what I tell parents is give one, and an hour later, if you don't have the results that you desire, then you give the other medication. The important piece of this, though, is that Motrin is given every 6 hours and not any sooner, and Tylenol can be given every 4 hours and not any sooner. So it's just so whenever they give those doses, they're careful about when they're giving the next dose. All right, moving on. Acute pharyngitis, inflammation of the throat. Typically, we see these as streptococcal infections, but half of these cases are viral in nature, and probably most of us have had a sore throat for a few days. It was a viral that did not require antibiotic treatment. Seasonal, late winter and early spring is the height of the pharyngitis season. It's very easily spread with large respiratory droplets. So on page 833, you'll find the symptoms of pharyngitis, sore throat, and pain with swallowing. When you think about strep throat, you almost have to think about somebody, it feels like somebody took a rake down your throat. Not fun. And then on visual exam of the pharynx, you may see anywhere from mildly red to very inflamed mucous membranes. Purulent exudate can be present. If it's a streptococcal infection / bacterial, a fever usually accompanies this with enlarged lymph nodes. These patients do not have coughs, and diagnosis is through a rapid strep screen. You need to be careful because patients with strep with difficulty swallowing or not eating and drinking, so very often dehydration can accompany these disorders. So how we treat them? We give them pain meds, we give them antipyretics and treat their fever, and just other supportive care such as warm liquids, rest. We might ease sore throat pain. There's a patient playbook that focuses on that on page 833 for you. We talked about Tylenol and Motrin dosing. Strep, if it's a strep infection, patients have two options. They can take an IM penicillin, a one-time dose, so therefore there's no going home and swallowing any more pills and less overall headache and hassle for these patients. Or they send them home on oral antibiotics, in which we need to encourage them to take the full dose. But some children are very challenging to get to swallow medication, so sometimes that IM injection is the best route. So that should be offered always as an option to parents so that they can decide what works best for their child. All right, tonsillitis, adenoiditis. The location of both the tonsils and the adenoids makes them very prone to infection. These are lymphoid tissues in the back of the throat. They can These infections can be both viral or bacterial in nature, and again, it's strep, mostly found in kids 5 to 15 years of age. We talked a little about this, very painful swallowing, sore throat, fever. They may snore, they may have a change in their voice quality. If their adenoids are involved, their breath may be foul, they may have recurrent ear infections, and you have maybe heard or known somebody who's had an adenoidectomy because of their chronic or recurrent ear infections. On physical exam, we're going to be seeing red and inflamed tonsils. Lymph nodes are going to be swollen. There may be a white or a yellow coating on their tonsils. Again, the diagnosis is through a culture, so you stick a long Q-tip back there and scrape their tonsils and send that off. If we want to rule out systemic infection in these patients, then we're going to draw a CBC in a monospot and do some electrolytes. I talked about dehydration earlier. It's a very real and common, side effect of patients or complications of patients with these disorders because they're not eating or drinking because it hurts too much. So I always tell my moms, especially in my pediatric population, or even my adults, douse yourself with some Motrin and then eat 45 minutes later. Otherwise, in the acute phase, they need rest, they need fluids, they could use warm liquids. They may even prescribe some steroids if the throat is very inflamed and swollen. These patients for complications, especially managing their pain. The biggest complication to be concerned about is hemorrhage. We have talked already in class a lot about what a patient with hypovolemia looks like. They have low blood pressure, they're tachycardic, they're pale. These patients may be throwing up bright red blood. And we want to especially look for these problems the first 12 to 24 hours, and then again, secondarily, 5 days out. You need to educate your patients, and they need to report the following things to their physicians. Throwing up or spitting out frank blood, so that's bright red blood, nausea and vomiting, fever, excessive swallowing or coughing. That can mean that they're swallowing blood. Secretions increase, it may be bloody, or even coughing, they may be stimulating their gag reflex in the back as the blood's running down the back of their throat. Also, if they have no pain relief, they need to be reporting that to their doctors. Other things that we can do for pain relief, we can have the patients lie prone with their head to the side. We can apply an ice collar. We can help them expectorate secretions. Ice chips, cool liquids. Tylenol with codeine is a very common medication sent home for these patients, but sometimes it's just plain old Tylenol. So we want to keep them hydrated, give them very soft, simple foods. I know when my daughter had hers out, she was loving the milkshakes, but it's pretty painful for her, so even the milkshakes were hard for her to deal with. No smoking for that patient, or no secondhand smoke in the home if the parents smoke. So a little history that you need to clear out there, or just throw that in when you're educating your patients. They shouldn't do any heavy lifting for 10 days, and no gargling post-tonsillectomy. All right, peritonsillar abscesses basically is just a local accumulation of pus. Teenagers and young adults, 15 to 35, are most at risk for these. They come in, they have a very sore throat, swallowing is painful, they may have fever, headache, neck pain, ear pain. One of the telltale signs for these patients is that plummy or potato voice, and they are typically dehydrated because they're not eating or drinking due to the pain. On physical exam, you might find a displaced tonsil or a swollen red soft palate. So the treatment is easily managed, usually as an outpatient in the emergency department or urgent cares. And that would be needle aspiration of that pocket of pus. If the patients can't open their mouths and we're just not sure diagnostically on physical exam, that's a problem, we'll do a CT scan. So they get a course of antibiotics, they get some steroids, and we drain that abscess. Educate them on are cool water mouthwash. Gargles, they should be gargling every 1 to 2 hours for 24 to 36 hours. Irrigation and topical anesthetics will help promote some of the pain relief for these patients. Okay, laryngitis. Well, laryngitis, acute or chronic. Typically, acute laryngitis is from voice misuse, environmental pollutants, noxious exposure. Common colds can cause an acute entity of this, and maybe you've all seen this with the, maybe you've been to a concert where you've been screaming, or just to any type of loud event where there's a lot of yelling going on and you lose your voice the next day. That's cute. I always think of like John Gruden of the Bucks, because he is a man who stood on the sidelines and screams and yells like most football coaches. And whenever you would hear the man in an interview, his voice just sounded awful. And I was always thinking this, that he's always going to need some surgical intervention for his vocal cords and how he's misused his voice. But other chronic things, cigarette smoking, air pollution, asthma inhalers can be a cause of chronic. GERD can be a cause of chronic laryngitis. Because as you have reflux, gastric reflux of your contents, it irritates and inflames your larynx, and so you lose your voice that way. So there's a big history and physical component, mostly history here. You need to get that medical history and know their underlying problems and what medications they take. So you can identify, like in my mother's case, when she had her trauma, she lost her voice, and we're all wondering what the problem was, but it wasn't long till we figured out that it was because she wasn't on her Protonics, which she was on at home. It just got biased, and she was, when you're in a trauma situation, it doesn't take long for things to get by you. But started Protonics, and her voice issues resolved rather quickly. These patients are hoarse for 7 to 10 days. They may have upper respiratory infection symptoms that accompany the hoarseness. And we can treat them either the underlying disease, sometimes antibiotics are indicated, it's kind of on an individual basis. So what should you as a nurse tell these patients? Well, rest your voice. Be quiet. Keep your mouth shut. Shut up. Yeah, that's always fun to say to patients. Stop smoking. Rest. Avoid whatever environmental irritants that you're exposed to. Cool liquid intake, humidifiers, and vaporizers. So those are things we can teach our patients. Next disorder I want to discuss, which is I have some personal experience with now, is sleep apnea. Sadly, and this has just been in the forefront of the news lately, that most of the people with sleep apnea go undiagnosed. If you're a man or an African American, you're at greater risk. If you have a family history, if your thyroid is low functioning, or you have hypothyroidism, a recessed chin, a large neck, you're a smoker, you use sedatives, or you drink alcohol, you are at a higher risk to develop sleep apnea. There's some types of sleep apnea, 3 types actually, well 2 in a mix, so obstructive or central sleep apnea, and then mixed. So when you're obstructive, it's mostly the most common type, and it's of the upper airway tract, where you have some type of obstruction. Central obstruction is where your brain fails to trigger the muscles of respiration, and a mixed obviously is a combination of both. The common denominator in all of these is that all patients drop their SaO2s. And Research has shown that we are developing very serious complications of our heart and lungs if this goes untreated. And the other piece of information I found interesting, it was up to 50% of patients with sleep apnea have hypertension. So on physical exam, we're going to find a narrowed oropharynx. Tonsils may be enlarged, tongue may be prominent, your nasal septum may be deviated. They tend to report loud snoring or snorting. In fact, most patients seek care because a significant other, a spouse, or whomever is sleeping with them notices that they stop breathing or snore loudly, or have episodes where they stop breathing. Other symptoms can be morning headaches, daytime somnolence, and overwhelming fatigue, memory, and personality problems from being sleep deprived. So the diagnosis starts with a history and a physical. Of course, we want to do blood work and rule out vitamin deficiencies and thyroid issues, but we do sleep studies on these patients. Most of the time now we're doing those at home, but they can be observational sleep studies in facilities where we look at the rate and the respiratory effort. We look at heart rates, airflow, SaO2s. We can put an EEG on patients and see brain activity, monitor their eye movement, and their muscle activity. So they're very fascinating studies. If you've ever seen one, my daughter had an inpatient one. She looked like a total alien. I was just really disturbed the whole night, wondering how the girl was ever going to sleep. So it's fascinating what they can find out through these studies. The treatment, though, the big treatments are lose weight and CPAP. Quit drinking, quit sedatives if you take them, but CPAP is continuous positive airway pressure that forces air down into your lungs, that helps keep your airways open, and even opens your alveoli so gas exchange can take place. In severe cases, surgery may be indicated, but nurses need to be supporting the patients. There's a lot of patient education that's involved. So funny because I have a CPAP machine now, and I think this girl sat down and told me in like 10 minutes how to use it, and there's really a lot to it. The bigger piece of it is they're acclimated to kick up when you have an apneic spell. So you start putting them on, they're very low flow, but they trigger when you have an apneic spell. But it's so, they have filters, they have tubing, they have distilled water, and all of those things have different instructions for how to clean them. And so that's the greatest challenge, I think, of having the CPAP machine. But they're amazing. They work really well. Okay, epistaxis, nosebleeds. A couple types of those. They can be anterior or posterior. So when the patients come in, we develop that history. When did it start? What precipitated it? What makes it better? What makes it worse? How many nosebleeds have you had? Any other symptoms associated with it? And then we do that physical exam, or that physician does, where he examines the nose and determines whether it's either an anterior or posterior bleed. If it's an anterior bleed, which means it's coming from the nasal septum, the most common bleed, we like to just apply pressure, direct pressure. So we lean that patient forward and we pinch the soft anterior portion of their nose against the nasal septum. If that doesn't do the job, we can pack their nose with some gauze for about 10 to 15 minutes, and that gauze can be soaked with either nitrates, cocaine, lido, or epinephrine. And a lot of times it's cocaine. We carry liquid cocaine in our Pyxis in our emergency rooms, and it's just the easiest thing to grab. If it's a posterior problem coming from the posterior nasal cavity or nasal pharynx, then we're going to pack that patient's nose for 2 to 5 days with a nasal tampon or nasal balloon. And these patients are not happy. It's very uncomfortable to have a large wad of tissue up your nose for an extended period of time. So what we need to do as nurses is teach prevention. The two biggest causes of nosebleeds are picking your nose and dryness. So we want to discourage picking. We want to encourage them to apply petroleum jelly to those areas, utilize humidifiers, not smoke. If the patients are at risk, if they have a history of nosebleeds, then we don't want them blowing their nose forcefully, bending over, and they certainly should avoid high altitudes. After we get a nosebleed under control, then patients should not partake in strenuous exercise nor eat hot, spicy foods. And that, summarizes nosebleeds. They're simply managed as outpatient, on an outpatient basis. Fractures of the nose, result of blunt trauma. Noses, they swell, they bleed. You may have some periorbital ecchymosis around the eyes. You may even see a nasal deformity. Normally, history and physical will do this for us, but we can certainly get that x-ray if we need that definitive diagnosis. What do we do for these people? We give them pain medicine, we tell them to apply ice, we give them oral rinses. Not a lot of support medically. Yeah, you broke your nose, go home. But if there is a deformity that the patient just can't live with, then we can certainly get a plastic surgeon in. Nasal obstructions, some things that can obstruct the nasal passages can be either anatomic or non-anatomic. So in an anatomic sense, we're looking at deviated septums or polyps. Non-anatomically, it can be chronic sinusitis or allergies. Obviously, we want to remove that obstruction once we identify what the causative factor is. So nurses need to be concerned about airways here, keeping that head of the bed elevated for these patients, oral hygiene, and pain management. If we become concerned about laryngeal obstructions, these are the patients that can aspirate a foreign body. They can have epiglottitis, where the epiglottis becomes inflamed, and that can actually obstruct your airway. Anaphylaxis, where you get swelling and edema of your airways. Those are all reasons to get a laryngeal obstruction, which obviously you think those things can be fatal and very serious or fatal. So the infectious or inflammatory process comes into play. Bronchoscopy can sometimes go and extract a foreign object. You remember the video where she dropped the piece of the saline pillow down the trach? Epinephrine, steroids for inflammation, ice, and then if they are obstructed with foreign body, the abdominal thrust procedure is a red flag chart on page 8 to 39 for your review. Certainly airway becomes the priority in these patients. We just talk about ABCs a lot, and this would be a big area for that. Anything head and neck, especially neck, you always need to be thinking airway, airway, airway. Laryngeal cancer. Most common sites for laryngeal cancer are the epiglottis and the true vocal cords. Men are at greater risk, and for some reason people in Spain develop a lot of this type of cancer. They're usually in the 5th and the 6th decade of life, and African Americans are more at risk. The most common cell type here is squamous cell, and the causative factors are smoking and alcohol. Alcohol is seen to have a synergistic effect with smoking to cause laryngeal cancer. So these patients may be hoarse for a couple weeks. The sore throat, cough, pain, difficulty swallowing. They may be able to palpate a lump or a mass in their neck. And so diagnosis, a complete history. So on page 841, there's a set of questions that will help you with that. Head and neck exam we discussed, and an indirect laryngoscopy or a biopsy. So stick that scope down, take some tissue, send it off for pathology to get a cell type and report. When it comes to the extent of the cancer, and whether or not it's metastatic in nature, then we look at CTs and MRIs to go that step further. So treatment really depends on the stage. Box 31-1 on 842 talks about the TNM system. Please don't memorize this. Just know that the stages, the treatment depends on the stage. Radiation will cure stages 1 and 2 of this type of cancer. Typically, we have chemo and radiation for stage 3 and 4. Surgery is always an option too. Sometimes we will radiate a tumor to shrink it before we go in and try to remove it. And so we're going to get to surgery in a minute, but when we talk about radiation, there's many side effects associated with that of the head and the neck. First, it decreases your mucus production. It causes mucositis. You may develop ulcers in your mucous membranes. May develop xeroxtoma or dry mouth. Their taste buds are diminished. Difficulty swallowing, sore throat, fatigue is almost always a major symptom of any radiation to any piece of the body, and skin irritation. So these patients with this neck radiation, they're not eating, they're not drinking, they're in pain. Food doesn't taste good to them anymore, so nutrition becomes a very high priority for them, and how you're going to manage that. They may need G-tube feedings, they may need TPN, they need IV fluids. All those things are important to consider in these patients. If the surgery comes into play, then we're looking at total laryngectomies for advanced tumors that radiation chemo aren't taken care of. One of the goals of patients that have this type of surgery is communication. So we have to think about alaryngeal voice, so methods of speaking without their larynx. Now your book goes into this on page 843. It talks about esophageal speech, transesophageal speech, artificial speech, devices like an electrolarynx, and then speech therapy. Should see these patients pre-op and help plan how they're going to communicate. This takes a multidisciplinary approach. Other alternative communication methods can be writing on paper, lip speaking, keyboards, whiteboards. So there's options, and that needs to be planned pre-op so the patient knows how they're going to talk to, staff and family post-op. We talked about nutrition a little bit. They have no PO intake for 10 to 14 days. They need IV fluids, 2 feedings, TPN. We said that already. Diet should consist of high protein, high calories, and hydration. So PO, when they start to take PO, you'll be thickening their liquids with thickened liquids. Sweets are discouraged because that increases saliva. They need to eat slow and chew well and have smaller portions. Total laryngectomy patients cannot aspirate. That's a key point. So that's good news. Education centers around physical, social, psychosocial, and spiritual. So on page 845, there's a home care list for your review for these patients. So this is just a very general overview of upper respiratory infections, chapter 31. And I'm going to look at the lower respiratory infections and try to get that to you Tuesday. I am sorry for the delay with the audio issues, but I'm hoping this resolves them. If it doesn't, I'm not really sure what I'm going to do next. So have a good evening. I hope you have a great weekend, and I will see some of you tomorrow, Monday, and the rest of you on Wednesday. Thank you.